Namaste Vidya, Hamisha Kush raho Vidya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue from our last lecture of rheumatoid arthritis. In the last lecture, we had discussed about the definition, etiopathogenesis, and clinical features of rheumatoid arthritis. And today, we are going to continue from the previous lecture. Before we start with the previous lecture, let's have a quick review of the topics that we have discussed in the last lecture. In the last lecture, we had discussed about rheumatoid arthritis, the definition of rheumatoid arthritis. Let me revise the definition. Rheumatoid arthritis is basically a chronic inflammatory disease of unknown etiology, which is marked by symmetrical peripheral polyarthritis. It is more common form of chronic inflammatory arthritis, and it is not only involving the joints, but also many other systems of the body. So it is a chronic multi-system disease of unknown etiology characterized by persistent inflammatory synovitis, usually involving peripheral joints symmetrically. It often results in joint damage and physical disability. Hallmarks, we have discussed about the hallmarks of rheumatoid arthritis, which includes cartilaginous destruction, bony erosion, and joint deformities. About the etiology and pathophysiology, we have discussed about the incidence that it occurs in around 0.5 to 1% of the population, with tendency for women to get affected more in comparison to men in the ratio of 3:1. The incidence of rheumatoid arthritis increases in the age between 25 to 55 years of age, and it is having both genetic and environmental factors that are responsible for development of rheumatoid arthritis. There is an association with HLA-DR4 gene. In the pathophysiology, we have discussed various factors. The factors which we have studied in the last lecture includes it is an immunologically mediated event in which the joint injury occurs from synovial hyperplasia, lymphocytic infiltration of the synovium, local production of cytokines and chemokines by the activated lymphocytes, macrophages, and fibroblasts, and these act on the endothelium, synovial fibroblast, bone cells, and chondrocytes to promote swelling and congestion of the synovial membrane and destruction of the bone, cartilage, and soft tissues. We have also discussed that all these changes that are occurring in the rheumatoid arthritis are because of the B cells that are releasing immunoglobulins, which includes rheumatoid factor RF, which can form immune complexes within the joint and in extra-articular tissues, leading to vasculitis. We have also discussed that lymphoid follicles from within the synovial membrane form inflammatory granulation tissue that is known as pannus, which spreads over and under the articular cartilage, which is progressive, eroded, and destroyed. There is a fibrous and a bony ankylosis, which occurs. Muscles adjacent to the inflammatory joints atrophy and is infiltrated by the lymphocytes. We have also discussed about the rheumatoid nodules that develop in rheumatoid arthritis, and it consists of central area of fibrinoid material that is surrounded by palisade of proliferating mononuclear cells. The lymph nodes in rheumatoid arthritis are hyperplastic, showing the lymphoid follicles and numerous plasma cells. Rheumatoid arthritis is characterized by infiltration of synovial membrane with lymphocytes, plasma cells, and macrophages. We have also discussed about the clinical manifestation, which is quite variable. The patients presents with inflammation of the joints, tendons, and dorsum, and there is early morning stiffness, which lasts for more than 1 hour and eases with physical exertion. There is earliest involvement of the signs that are typically of the small joints of hands and feet. The pattern of involvement can involve single joint, that is known as monoarticular, few joints, that is oligoarticular, involving 4 to 5 joints, and polyarticular, that is involving greater than 5 joints. The involvement is usually symmetrical. It is symmetrical in distribution, and once the disease process of RA is established, the wrist, metacarpophalangeal joints, and proximal interphalangeal joints are most frequently involved joints. The joints are tendon and swollen, and there is serum rheumatoid factor positive and anti-CCP, that is anti-cyclic cetrolinated protein antibodies, are present with the highest score for physical disability. This we have discussed in the last lecture. Today, we are going to start with the deformities. Deformities that we are going to see in case of rheumatoid arthritis. There are different types of deformities that are commonly seen in rheumatoid arthritis. And it occurs due to progressive destruction of the tendon, joint capsule, and soft tissue that may lead to chronic and irreversible deformities. There is flexor tendon tenosynovitis. It is a frequent hallmark of rheumatoid arthritis and leads to the decreased range of motion, reduced grip strength, and trigger fingers. This is like a trigger finger. So, progressive destruction of the tendons, joint capsule, and soft tissue leads to the chronic irreversible deformities. Flexor tendon tenosynovitis, it is a frequent hallmark of rheumatoid arthritis and may lead to a decreased range of motion, reduced grip strength, and trigger fingers. Ulnar deviation, this is the ulnar deviation. It results from the subluxation of the metacarpophalangeal joint with subluxation of the proximal phalanx to the volar side of the hand. There is also swan neck deformity. We have a swan neck deformity in which there is hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint. This way, hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint. This is known as swan neck deformity. I have shown the pictures of all these things in the presentation that I have given on the portal. So there are various types of deformities. We have swan neck deformity, we have ulnar drift, ulnar deviation, and other. We have also Z deformity and other deformities. So I have discussed all these deformities with pictorial representation in the PPT. So go through the presentation that I have uploaded on the portal. Other deformities includes both honorary deformity, in which there is flexion of the proximal interphalangeal joint with the hyperextension of the distal interphalangeal joint, this way. So there is flexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint. We have Z-line deformity in which subluxation of the first metacarpophalangeal joint with hyperextension of the first interphalangeal joint take place. I have given the pictures of all these disease conditions, so you can go through them in the presentation. We also have piano key movement. Piano key movement consists of inflammation about the ulnar styloid and tenosynovitis of the extensor carpi ulnaris causes subluxation of the distal ulna. Another deformity, we have flat foot, that is known as pes planovalgus. It is a chronic inflammation of the ankle and the mid-tarsal regions lead to flat foot. So we have discussed about the both honorary deformity. We have discussed about the Z-line deformity. We have discussed about the piano movement. We have discussed about the flat foot. And also we have discussed about the flexor tendon tenosynovitis and swan neck deformities. All these deformities are very common in rheumatoid arthritis. Many times you get a question in the examination related to the deformities that are commonly seen in rheumatoid arthritis. Now we come to the extra-articular manifestations. What are the different extra-articular means? The manifestation other than the joint that are seen in case of rheumatoid arthritis. As we know that rheumatoid arthritis is a systemic disease and it results from a variety of extra-articular manifestations. It develops in the people having the history of smoking. They have early onset or significant physical disability and test positive for serum rheumatoid factor. The constitutional signs and symptoms includes weight loss, we have fatigue, malaise, depression, and the more common severe cases, cachexia. So what are the extra-articular manifestations? There are various manifestations which develop in the people or the patients having the history of smoking, and they have early onset with physical disability and test positive for rheumatoid factor. The constitutional signs and symptoms includes weight loss, we have fever, fatigue, malaise, depression, and the most severe cases, cachexia. There are various extra-articular manifestations. Let me discuss them one by one. The extra-articular manifestations are related to various systems, which includes cutaneous symptoms, pulmonary, ocular, hematological, cardiac, neurological, and others. So in the cutaneous manifestation, we can see rheumatoid nodules that we have just discussed previously. There will be vasculitis. In the pulmonary manifestations, there will be nodules and interstitial diseases. Ocular manifestations, which consist of keratoconjunctivitis sicca, episcleritis, and scleritis. There are also hematological manifestations, which includes anemia, Feltes syndrome, which includes splenomegaly and neutropenia. There are cardiac manifestations, which include pericarditis and myocarditis. And also there are various neurological manifestations, which includes myopathies secondary to cervical spine disease and entrapment vasculitis. So let me repeat the extra-articular manifestations. In the extra-articular manifestation, we have cutaneous manifestations, which consist of rheumatoid nodules, vasculitis, pulmonary nodules, interstitial disease. We have ocular manifestations, which includes keratoconjunctivitis sicca and episcleritis. There are also various hematological manifestations, which includes anemia, Felty's syndrome, splenomegaly, and neutropenia. Various cardiac manifestations, which include pericarditis and myocarditis. Neurological manifestations, which include myelopathies secondary to cervical spine disease, entrapment, and vasculitis. I have also shown the picture in the presentation related to all these systemic manifestations, how they exhibit in the individual. Now, what is the criteria? How will you diagnose a case of rheumatoid arthritis whenever a patient of rheumatoid arthritis is coming to us? How will you diagnose for that given condition? The diagnosis of rheumatoid arthritis is made with 4 or more of the following features. If more than 4 of these features are present, then we can diagnose the patient as rheumatoid arthritis. Number 1, we have morning stiffness. Morning stiffness which remains for more than 1 hour. We have arthritis that is occurring for in greater than 3 or more joints. We also have rheumatoid factor, presence of rheumatoid factor, various radiological changes that could be seen in the X-rays, arthritis of the hand joints, and symmetrical arthritis. The duration has to be greater than 6 weeks and presence of rheumatoid nodules. So let me repeat the criteria for diagnosis of rheumatoid arthritis. In rheumatoid arthritis, we have to check for 4 or more of the following features to be present for the diagnosis of rheumatoid arthritis. Number 1, we have morning stiffness for greater than 1 hour, arthritis of 3 or more joint areas, rheumatoid factor, radiological changes, arthritis of the hand joint, symmetrical arthritis, and duration greater than 6 weeks, and also presence of rheumatoid nodules. Now, how to differentiate? What are the various conditions which resembles the case of rheumatoid arthritis? The differential diagnosis consists of gout, SLE, we have psoriatic arthritis, infectious arthritis, osteoarthritis, and sarcoid. So differential diagnosis, the various diseases which resembles rheumatoid arthritis includes gout, SLE, psoriatic arthritis, infectious arthritis, osteoarthritis, and sarcoid. Now, what are the difference between osteoarthritis and rheumatoid arthritis? In osteoarthritis, we have the joint pains in few locations, and the morning stiffness is less than half an hour with mild swelling. There are no systemic problems in case of osteoarthritis, whereas systemic illness is present in rheumatoid arthritis. The morning stiffness, which is only for half an hour in osteoarthritis, is greater than 1 to 2 hours in case of rheumatoid arthritis. In osteoarthritis, only few joints and smaller joints are involved, whereas in rheumatoid arthritis, more joints are involved with symmetrical involvement. In case of osteoarthritis, there are no rashes, no fever, systemic signs, pain causes symptoms, and osteophytes are present. Whereas due to systemic illness, in rheumatoid arthritis, we can see fevers and weight loss. There is muscle atrophy. Internal organ problem consists of 25%. Eyes are involved in 25% or more. In the skin, we have rashes, nodules, vasculitis. In the lungs, heart nodes. Now, how to evaluate the evaluation of the case of rheumatoid arthritis? Whenever a case of rheumatoid arthritis is coming to us, we have to take the proper history and do the physical examination. So proper history taking and proper physical examination has to be done. Presence of rheumatoid factor is present in 66% of the patient. Its presence correlates with the severity of the disease, nodules, and extra-articular manifestation. So more is the level of rheumatoid factor, more is the severity of the disease. Antibodies to cyclic citrullinated protein or anti-CCP antibodies have similar sensitivity but higher specificity to rheumatoid factor. Present most common in the patients with aggressive diseases with a tendency for development of bony erosion. Radiographs shows juxta-articular osteopenia, joint space narrowing, and marginal erosions. So in the evaluation, we have to check for rheumatoid factor, we have to check for anti-CCP antibodies, and we have to check for the radiographs, that is X-rays, which includes juxta-articular osteopenia, joint space narrowing, and marginal erosions. Now we come to the treatment part. Whenever a patient of rheumatoid arthritis is coming to us, how can we treat the patient? First of all, patient education is very important. Patient education on the disease and joint projection. Physical and occupational therapy considered assistive devices, aspirin for non-steroid or non-steroidal anti-inflammatory drugs. Intra-articular glucocorticoids can be given along with systemic glucocorticoids. There are various disease-modifying anti-rheumatic drugs that is known as DMARDs, example, methotrexate and sulfasalazines. Surgery can be done in severe functional impairment due to deformity. So the treatment, I will repeat the treatment part, the patient education or the disease and joint protection. We have physical and occupational therapy, which consists of assisted devices, aspirin or non-steroidal anti-inflammatory drugs, intra-articular glucocorticoid injection can be given, systemic glucocorticoids, DMARDs, that is known as disease-modifying anti-emetic drugs, which includes methotrexate and sulfasalazine, and surgery in case of severe joint deformity. So this was all about rheumatoid arthritis. There are various homeopathic medicines which can be given. Although homeopathic treatment is based on the constitutional or symptom similarity, but there are some therapeutic medicines which can be given. Therapeutic medicines includes Vestox, Actias picata, Pulsatilla, Calmia latifolia, Primea, Colophyllum, Antimcrude, Causticum, and Ledum palm. So this was all about rheumatoid arthritis. In the next lecture, we are going to continue with ankylosing spondylosis. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH from University. I hope you have understood this session properly. If you have any query, please mention in the comment box and I'll try to resolve. So this was all for today. Thank you very much. Have a good day.